Hello, we will be presenting diabetes mellitus with a special consideration to the elderly population. We'll start with our objectives for this review. We will just understand the consequences of the diabetes in the geriatric or the elder population, and how to establish a diagnosis and manage the challenges associated with the diabetes, like the hypertension, the dyslipidemia, the microvascular complications in the patient with diabetes. I will also discuss the dosage and formulation of the antidiabetic agents. As we said, the topic covered are also including the epidemiology of diabetes in the older people and the consequences of diabetes in the same population, and also classification of the diabetes, the pathophysiology, and how to establish a diagnosis and manage the complication and the diabetes itself, and how to educate your patient and self-manage. The epidemiology of the diabetes. So, as we said, that diabetes is of growing concern, and especially in the elderly population. So, the population of the elderly patient is rapidly growing, and a significant impact on the population, health and economic. It affects about 15 to 20 sometimes more than 20% of the people over the 65 of age. One of the most chronic diseases in this age group, and currently in the United States, the older adults over the age of 65 make up more than 25% of the total population with diabetes. So even if the incidence rate were to level off, the prevalence of diabetes will double in the next 20 years as the population will age. And there is also a higher prevalence of diabetes among the Black and the Hispanic communities than in the white American communities. The consequences of the diabetes, as we can say, there is a lot of challenges, and they have a higher risk of acute and chronic microvascular complication from the disease. And plus they have, as we can see, like 10-year reduction in the life expectancy, twice higher the mortality rate, twice higher the risk of atherosclerosis, the neuropathies, loss of vision, and renal insufficiency, and twice as higher rates of myocardial infarction, stroke, and kidney failure, 40% higher risk of blindness, and 2 to 3 times higher the risk of mobility disabilities, and 1.5 higher risk of disability in the daily living activities. Continuing, in the elderly population per se, we have what we call as a geriatric syndrome, which is some of those which can present in the diabetes, can complicate or challenge our management of the diabetes, which are incontinence, depression, cognitive impairment, urinary incontinence, injurious falls, chronic pain, and polypharmacy. Here we're going to address the classification of the diabetes. There's type 1, type 2, and there's also a third category. Type 1 also is type 1 results from the absolute deficiency in the insulin secretion, which is an autoimmune destruction of the pancreatic beta cells cannot produce the insulin, while type 2 is the resistance to the insulin action, which is present in the majority of the cases. The third category, which is secondary to an injury to the pancreas or any other abnormalities that causes increase in the glucose in the blood. Pathophysiology of diabetes. In the elderly population, about 90% of the older adults with diabetes have type 2. as we said, type 2 is more prevalent in the elderly population. The diagnosis usually follows years of pre-diabetes, which consists of either glucose intolerance, insulin resistance, and metabolic syndrome, which the pre-diabetes itself have been proven to be by itself uh, comprised at a higher risk of atherosclerosis. So the prevalence of diabetes increases with age, as we said. But there is another factors that can contribute to the incidence of diabetes, which is genetics, lifestyle, and the influence of aging, certain medications, intercurrent illnesses, and other physiological changes. The pathophysiology also is similar in the younger and the older adult. Basically the prolonged hyperglycemia may lead to protein glycosylation and accumulation of the abnormal proteins, which leads to tissue damage. And also the hyperglycemia can lead to the accumulation of the metabolic products, which are a result of the aldose reductase system and leads to impaired cellular energy metabolism. The physiological changes due to diabetes and its complication may interact with the changes due to aging and may furthermore decrease the physiological reserve of our patients. How to treat with or interpret the borderline results. Borderline results are basically considered impaired fasting glucose if the fasting blood glucose is between 110 and 125, which is associated also with increased risk of diabetes, and isolated post-challenge hyperglycemia, which is the fasting is not elevated, and many of those patients have been diagnosed with the type 2 diabetes by the OGTT criteria, appears to increase risk of atherosclerosis, although not as much as a type 2 diabetes. Alright, moving on to the clinical evaluation of the older adult with diabetes. The older population with diabetes requires specific consideration and unique consideration. As we can say, they are not only they have to be assessed for other geriatric syndrome, which the following considerations are useful when we develop the treatment plan or our treatment goals for the patient and the management strategy. We have to evaluate for risk factors for atherosclerotic disease and the presence of any comorbid diseases. Take also thorough medical history, as we can say the polypharmacy can affect the patient's management plan because too many medications make it very hard for the patient to remember, and assess the functional status of the patient, screen also for the geriatric syndromes, which is multiple medications, depression, again cognitive impairment, urinary incontinence, injurious falls, and chronic pain, presence of any of which can make it very challenging for the patient to keep tracking and control his blood sugar. And also assess the need for diabetes education and self-management and social support, and whether the patient needs any caregiver, whether he's living any support around him, or is he living if the patient live in any specific nursing home, or he needs any specific or special care. Okay, the goals are, as we said before, taking into consideration the elements as we said. Our goals are to control the hyperglycemia and the symptoms of the hyperglycemia. We have to evaluate the patient and treat it for any associated risk for atherosclerosis and microvascular disease, and also evaluate for any diabetic complications. Support the diabetes self-management and education, maintain and improve the overall and health of the patient. Alright, so moving on to the management of diabetes, or the principles of management diabetes in the geriatric population. The presence of any of the age-related conditions, as we said, both aging and diabetes increase the risk of certain comorbidities, the geriatric syndrome, which includes cognitive function, depression, functional disabilities, and falls, fractures, polypharmacy, chronic pains, and urinary incontinence. It is important to recognize these conditions because they can interfere with the patient's ability to perform diabetic self-care, and if the clinicians are not aware of those, they may prescribe treatment that is too complicated or too complex for a patient with a cognitive dysfunction, for example. Alright, so older adults should have same opportunity as a younger adult for intensive diabetes management, reduction of risk associated with diabetes, and treatment of any comorbid conditions. For some older patients, intensive management of diabetes and its complication is not likely to provide benefits and may even be harmful because there is a wide spectrum of the older population health. Some elderly people can be healthy as the young people, and some of them are so frail. So diabetes management and goals should be tailored according to the patient's personal individual health. Alright, so how to prevent and manage the cardiovascular risk factors. First of all, we have to counsel the patient regarding maintaining an appropriate weight, increasing the physical activity, discontinuing smoking, if any, and limit any unhealthy behavior or unhealthy food behavior, limiting fat and carbohydrate intake. We have to also consider any drug therapy. Consider treating the patient with hypertension, preventing MI with aspirin, and treat the hypolipidemia. Move on to managing hypertension in the elderly population with diabetes. The target blood pressure is 140/80 for most patients, but some observation studies suggested that the target of 130/70 may provide an increased benefit for those patients. Lowering the blood pressure, of course, will be gradually to avoid any complications, and most of the antihypertensive drugs have comparable effectiveness, but the widely used are the ACE inhibitors and ARBs, which is angiotensin receptor blockers, because they have special cardiovascular and renal benefits for the diabetic patients. For managing the dyslipidemia or hyperlipidemia in older population with diabetes, the dyslipidemia should be corrected if reasonable considering the patient's overall health. As we said, any management for elderly population, for the elderly patient with the diabetes, we need to take into consideration the whole picture, all the overall health of the patient, the presence or not of any of the geriatric syndromes also. Our target LDL should be lower than 100 milligram per deciliter, and if the LDL is more than 130, we should start any pharmacological therapy and plus the lifestyle modifications. And we need to measure the ALT within the 12 weeks of the initiation or any dose increase of the statin or niacin. Of course, measure the liver enzymes annually, or in some practices they measure it like every 3 months to keep track on the status of the liver while we are using the statins. Prevent and manage microvascular complication of the diabetes. We have to continue monitoring on the eye by doing a dilated eye exam by an eye care specialist. We should do a baseline eye examination at the diagnosis and repeat that annually if the exam detects retinopathy, other medical eye diseases or eye symptoms, or if the hyperglycemia or the blood pressure is poorly controlled. We should repeat the eye examination. Otherwise, we have to repeat it every other year. The foot examination is at least should be done annually. We should test also for microalbuminuria at the diagnosis and at least annually thereafter. And we should remember also to give the diabetic patient a pneumococcal vaccine. Regarding the antidiabetic or the oral hypoglycemic agent for treating diabetes, there is several classes of the oral hypoglycemic medications, and here we have the second generation sulfonylureas, which are the glimepiride, the glipizide. The glipizide other name is glucotrol XL, and glipizide generic name glucotrol. Glipuride generic is diabeta, and micronized glipiride. They are all under the class of sulfonylureas, second generation sulfonylureas. The dosage are for glimepiride are 4 to 8 milligram once. We need to start low and go slow. And for glipizide is 2.5 to 40 milligram, either once or divided. Also the glipizide, the other name glucotrol XL, we can start at 5 or 20 milligram once, and glipuride is 1.25 to 20 milligram once or divided. The micronized is 1.5 to 12 milligram. Okay. The alpha-glucosidase inhibitors, which is acarbose and miglytol. For acarbose, the dose is 50 to 100 milligram every 8 hourly, just before the meals. It starts with 25 milligram per day. The side effects of the acarbose, of course, are GI adverse side effects, and you should avoid the acarbose if the patient have creatinine more than 2 milligram per deciliter, and we need to monitor the liver enzymes. For miglytol, the dosage are 25 to 100 milligram, which is also given 3 times a day with the first bite of the meal, and it starts with 25. And the same side effects, GI side effects, but here with miglytol we don't need to monitor the liver enzymes. The DBB4 enzyme inhibitors, they are saxagliptin and sitagliptin. The saxagliptin are 5 milligram, 2.5 if there is creatine, the creatine clearance less than 50 milliliter per minute, and sitagliptin is 100 milligram once daily as a monotherapy or in combination with metformin or thiazoles, 50 milligram per deciliter if the creatine clearance is 31 to 50, and 25 if the creatine clearance is less than 30. We need to monitor potassium. Alright, the biguanides, metformin, glucophage, the generic name. The dosage are 500 to 2550 milligram, which is divided. We have to avoid metformin in a patient more than 80-year-old unless the creatinine clearance is more than 60. For creatinine clearance more than 1.5 in men, or creatinine clearance more than for creatinine more than 1.5 in men, or creatinine more than 1.4 in women, or heart failure or COPD, elevated liver enzymes hold before contrast. Radiological studies may cause weight loss. Metformin, the other one, generic name glucophage XR, The dosage are 1,500 to 2,000, the same concentration as the metformin. Continuing on the oral non-insulin agents, the drug class is meglitinides. Meglitinides include the natglinides, Starlix, and ribaglinide, pranidine. The natglinide or the Starlix, the dosage are 60 to 120 milligram, is taken 8 hourly, and the ribaglinide 8.5 milligram taken every 6 hours or every 12 hours if the A1C is less than 8% or have been previously untreated. The dosage of 1 to 2 milligram every 6 hours or every 12 hourly if the A1C was 8% or more or have been previously treated. The mechanism of action of the meglitinides is increasing the insulin secretion, which lowers the A1C by 1 to 2%. It should be given 30 minutes before the meal for the Starlix, and for the Pradine should be given 30 minutes before meals as well, and should be adjusted weekly intervals for potential interaction, hepatic or renal insufficiency. The glipizide and metformin, called metaglip combination, can be used in a dosage of 2.5 to 250 milligram once, or 20 from the glipizide and 2000 from the metformin can be used in 2 divided doses. Okay, this combination should be avoided obviously in patients over 8 years old and patients with creatinine more than 1.5 in men and more than 1.4 in women. And the glipizide and metformin combination, called glucovans, the combination is 1.25 from the glipizide and 250 from the metformin initially if previously untreated, or 2.5 to 500 from the milligram, or 5 and 500 milligram every 12 hourly with meals. The maximum dose can be given is 20 and 2000. The starting dose should not exceed the total daily dose if either drug. The pioglitazones and the metformin combination is 50 milligram from the pioglitazone and 850 from the metformin, which is given 12 hourly or daily. And the ribaglinide and metformin combination, called Brandimet, which is 1 milligram and 500 milligram, or 4 milligram to 1000 milligram. It should be given twice daily or 3 times daily before the meals. The maximum dose allowed is 10 to 2500. Another combination is the rosiglitazone and glimepiride, called Avandrel. Avandrel is taken 1 to 2 tabs per day. The maximum is 8 milligram and 4 milligram. And rosiglitazone and metformin, which is called Avandamet, is 4 to 1000 or 8 to 2000 in 2 divided doses. And also, as any drug containing metformin, it should be avoided in patient over 80 and patient with creatinine clearance more than 1.5 in men and 1.4 in women. The pioglitazone and glimepiride combination, called Deutact, also had 32 and a maximum 45 to 8. The sitagliptin and metformin combination, called Janomet, should be begin with the current dose, and the maximum is 100 and 2000 in 2 divided doses. Moving to cover the thiolitizones, the bioglitazone Actos and the rosiglitazone Avandia. The bioglitazones have dosage of 15 to 30. The maximum is 45. It can be used as a monotherapy, or if we are using it as a combination, the dose is 30 milligram per day. The rosiglitazone, the Avandia, dosage is 4 milligram twice daily or once daily. The mechanism of action is they are insulin resistant reducers. They lower the A1C by 0.5 to 1%, but there is a risk of heart failure, so we should be avoided in NEHA class 3 or class 4 cardiac status, and they should be discontinued if the patient cardiac status declined. The bioglitazones, for the bioglitazone, we need to check the liver enzymes at the start, and then every 2 months for the first year, and after that periodically. And also should be avoided if there is any evidence of liver disease or the serum ALT have increased to a 0.5 higher the double the upper limit of the normal. And also they may increase the fractures in women. The rosiglitazones, they have probably higher risk of the cardiovascular disease than the bioglitazones and other or hypoglycemic agents. But also we need to check the liver enzyme at the start and at the same like the bioglitazone every 2 months during the first year. And the same consideration as the bioglitazone for the rosiglitazone. Injectable non-insulin agent for treating diabetes. We have exenatide and pramlintide. Exenatide dosage are 5 to 10 micrograms subcutaneously. It can be given twice daily, and the formulations are 1.2 to 2.4 milligram pre-filled syringes. The metabolism is it's an incretin mimetic, so it lowers the A1C by 0.4 to 0.9%. It can cause nausea, hypoglycemia, and commonly less weight gain than the insulin. It should be avoided if the creatine clearance less than 30. For the pramlintide, the dosage is 60 micrograms subcutaneously immediately before meal. The formulations are 0.6 milligram per ml in 5 ml vial. They are amylin analog. They lower the A1C by 0.4 to 0.7%. But they cause nausea and hypoglycemia, and commonly they reduce the pre-meal dosage of tea by 50%. Rapid-acting insulin preparation are present in many forms. There are several preparations of the rapid-acting insulin. One of them is the insulin glucosilin, the Abidra. It starts its action in 20 minutes and peaks in half an hour to 1.5 and lasts for 3 to 4 hours. And insulin Lispro, the Humalog, it starts its action in 15 minutes and peak also in half an hour and to 1.5 hours, and also last for 3 to 4 hours. The insulin Aspart is the Novolog. It starts its action in 30 minutes and peaks in 1 hour to 3 hours. It's double the time in the insulin in the Lispro and the Apidra, and lasts for 3 to 5 hours. Lastly, the regular insulin, the Humulin or the Novolin, it starts in half an hour to 1 hour and peaks in 2 to 3 hours. It lasts the longest, it's 8 to 12 hours. There is also a mixture of the NPH and the regular 50-50 proportions. That's some sort of preparation. Alright, the intermediate of the long-acting insulin preparation. The NPH insulin, which is the Humulin or the Novolin, it starts in 1 hour to 1.5 hours, peaks in 4 to 12 hours. It lasts for 24 hours. The insulin detemer, the levomer, starts in 3 to 4 hours and peaks for 6 to 8 hours and lasts for 6 to 24 hours as well. Insulin glargine or the Lantus, it starts its action in 1 to 2 hours and peak time is somewhere between 8 hours and 12 hours. There is no specific time. The duration is 24 hours. The isophene insulin and the regular insulin injectable, the Novolin, it's in 70 to 30 respectively. It starts its action in 30 minutes and peaks in 2 hours to 12 hours and lasts for 24 hours. Once we diagnose the patient with diabetes, it is crucial and important for the patient to understand the mechanism of the metabolic derangement and their management and become fully involved in the diabetes self-management and its monitoring and treating the disease and its complication. Therefore, the diabetes education and particularly the self-management is key part of the effective care. So it's often have to be accomplished in the primary care setting. Diabetes education program can be particularly important for older adults with diabetes who are part of the minority groups like Black Americans, Hispanic Americans whose diabetes is more prevalent than the white American. So if the patient is clinically complex, so consider referral to a diabetes educator, a disease management program, or even a specialty physician care. The annual diabetes self-management training is covered under Medicare Part B. You have also to involve and educate caregiver of the patient if the patient has any kind of cognitive impairment or he's disabled or frail or has any barrier regarding the language. Educating the patient and caregiver is, we have to address several points. We have to make sure that the patient understands the hypo and hyperglycemia, precipitating factors, how to prevent them, what the symptoms are, how to monitor, to treat, and when to notify the physician. And it's also important for the patient to understand the blood glucose self-monitoring when it's appropriate for them to know that. Diet, of course, and the physical activity, one of the first concepts to be addressed. Medications, why he has to take the medication, because this will affect his compliance. What are the side effects? What are the common adverse reactions for it? And finally, and the most important, I guess, the food care. He has to understand how to take care of his feet on a daily basis and to prevent any traumas or any complications that may occur. Although hypoglycemia is unusual for older adults, when they are treated with like sulfonylureas or insulin, older adults with diabetes are still at a higher risk than middle-aged people with diabetes to have hypoglycemia. To summarize, diabetes and impaired glucose tolerance are important to identify and address. Because of the great heterogeneity in the older population, treatment goals for older people with diabetes must be carefully individualized. Though the target is debated, we have to lower the blood pressure as tolerated. It's also important for the older hypertensive diabetic to have their blood pressure under control. The self-management is important. The diabetes self-care, the annual self-management, and also everything is covered under the Medicare Plan B or Part B. In this part, we are having here cases or clinical scenarios for diabetic patients. We have an 80-year-old man who's living in a nursing facility. He's been evaluated because of the gradual functional decline. He lost 4.5 kg, like 7% of his weight, since he entered the nursing facility 6 months ago after hospitalization for acute MI. During the hospitalization, type 2 was diagnosed. Type 2 diabetes was diagnosed. In the nursing home, he remained hyperglycemic with periodic blood glucose concentration are between 300 milligram, and the recent A1C level was 7.9. The patient is on an American Diabetic Association low-fat diet. He takes several medications, including glipizide, pravastatin, hydrochlorothiazide, metoprolol, lisinopril, and aspirin. His lab results are his creatinine is 1.4, the LDL is 100, and HDL is 34 milligram per deciliter, and triglycerides are 170. Which of the following is the most appropriate next step in managing this patient? Here is a patient who has been recently diagnosed with type 2 diabetes. He has myocardial infarction and he has polypharmacy, as we have seen in the previous slide. And what are the options for him? He still has his blood glucose is not under control. What's the thing that we need to do? A, increase the glipizide dosage, add metformin, add acarbose, add niacin, or liberalize his diet. As we have said before, it's it's less favorable for elderly patients to have a lot of medications. We have to first address the common things or the first things like his diet. So liberalizing his diet will be the best plan for him. Patient is especially is a grave risk for medical complications and death because of his weight loss and the functional decline. Moreover, the change of his medication regime has added risk for him. The most rational approach for this, vulnerable patients, they are already on a complex regime for a lot of medication, multiple medications, and increase his caloric intake. The other options, as increasing dose of glipizide to lower his A1C at this point, might increase the risk of hypoglycemia and death. In the second case, here we have 72-year-old man came to the office for evaluation. He has impaired fasting blood glucose. His fasting level were between 110 and 120 milligram on 3 occasions. He has well-controlled hypertension. His BMI is 29.5. So which of the following is the most likely to prevent the development of type 2 in this patient? Type 2 diabetes. A is to reduce the caloric intake and increase his physical activity to 150 minutes per week. Increase his physical activity plus metformin, or begin the metformin, or reducing the caloric intake. As we said before, it's very important for any patient to start with lifestyle modification. The most important aspect is to increasing the physical activity. So here we have A and B, both include increasing physical activity, but B said increase physical activity and begin metformin. So since we are laying off the medication for the elderly until we absolutely necessary need to do that, it's better and more rational to start with reducing his caloric intake and increase his physical activity. The landmark trial from the Diabetes Prevention Program research group evaluated patients at risk of new onset diabetes who were randomly assigned to number one, lifestyle intervention. The goal was 7% weight loss through reducing the caloric intake and increasing the physical activity by 150 minutes per week. And the other group is educational materials plus metformin, 850, 12 hourly, or educational material only. The participants were overweight and had both fasting and post-load hyperglycemia at the level and not yet diagnosed of diabetes. The lifestyle modification was the most effective approach to diabetes prevention. The incidence of diabetes in this group was reduced by more than 50% versus patients who received the educational materials or the metformin. So in the third case, here we have an 81-year-old woman is brought to the office by her daughter with whom she has been living since the recent death of her husband. She is a former smoker and drinks socially. Her history includes osteoarthritis of the hip and knees, hypertension, incontinence. She has recently which recently worsened and limits her willingness to leave home. She had a stroke several years ago that left her with some right-sided weakness for which she uses a cane. Medications include ibuprofen, glucosamine, hydrochlorothiazide, aspirin, multivitamin, and since her husband's death, fluoxetine. She started an SSRI. She's allergic to lisinopril. Her weight is 90 kilograms, 200 pounds, and height is 165. Her BMI is 33. Overweight. Her BP is 126/78. Pulse is 70 and regular. The patient has left carotid bruit, slight weakness and rigidity in her right arm and leg with associated gait abnormality and bilaterally decreased dorsalis pedis and posterior tibial pulses. Both feet have slight edema. She scores 29/30 on the mini-mental state exam and 11/15 on the geriatric depression scale. Alright, her lab results are her fasting is 165, hemoglobin A1C is 7.5, total cholesterol is 215, high density lipoprotein is 35, the LDL is 140, triglyceride is 200, her potassium is 5, her creatinine is 1.3. Fasting glucose level 2 days later is high, is 158. Urine analysis is positive for microalbuminuria. So which of the following medications is most likely to decrease her cardiovascular risk? Glipizide, metformin, valsartan, or simvastatin. Here we have a patient diagnosed with diabetes, and she has, as we can see, multiple comorbidities. And from the physical exam, we can see that she has a risk, and she already had a stroke, and she had a risk for further incidents. So the most thing that we need to do right now is to decrease her thromboembolic event, which is by adding simvastatin. As we said, she has evidence of stroke, peripheral vascular disease, and the most immediate threat to her health and substantial risk for further macrovascular complications. She already has aspirin in her regime. The only thing that we need to add for the patient with a proved mortality decrease is the statins. Thank you for attending the review of diabetes mellitus, which is a big topic regarding the geriatric population. And thank you very much.